Hi everyone, this is Neel Raithatha, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope, and here we had a really complex case of a patient who attended with a severely occluded and impacted wax buildup in their left ear. I'm using our medium-sized specular, which is a 4.25mm specular. This is the most common ones that I use. And if someone's got narrower ears, I will sometimes revert to our smaller pediatric size specular, which is 3.5mm. And we've got two larger ones, a 5mm and a 5.75. And there was elements of Keratosis obturans here because you'll see a bit later on, there was a white peripheral layer of skin, a matrix, which is a hallmark of Keratosis obturans. And the patient themselves did report some otalgia, so earache, which is another hallmark of Keratosis obturans. They do also have a skin condition, so for anyone who doesn't know what Keratosis obturans is, it's an accumulation of dead skin that forms into a plug in the ear. And this skin plug gets bigger and bigger as more dead skin is shed. And it typically forms in a lamellar structure, so like an onion-like structure, where these individual skin cells, as they shed and come off the surface of the ear canal, they should individually disconnect from one another. With Keratosis obturans, quite commonly, although the skin cells have shed it off the canal wall, they haven't lost their interconnecting links, so you get long chains of dead skin. And if someone's got a skin condition, of course you're going to have more dead skin in the ear, and that's that white peripheral matrix that's referring to. There was a slight widening in the midsection of the ear canal. And Keratosis obturans is more common with patients below the age of 40 as well. And possibly the reason for that is, one reason for a lot of dead skin is inflammation in the ear, or a high rate of blood flow. So the more inflammation, more blood flow you have in the ear, the more the ear turns over dead skin and produces new skin. So it did fit the classification of Keratosis obturans. And again, this is the widening, and you're going to see me bring in the skin plug. There is a bit of wax as well. Because it's a widening in front of the plug, the ear canal's narrow. So I'm having to almost drag this through this narrowing. You can see here, I'm trying to pinch it inwards. So this is the wider part. You can see the plug is coming from behind that visible flesh on the right-hand side. And it took a while. I did use forceps. I used the Rycorette as well, which all helped. And there's some residual skin on the eardrum that I also removed using a fine end suction probe. So this suction probe is a 14 gauge suction probe. This is the most common one that we use when performing microsuction. And they typically have an inner diameter of around, an outer diameter, should I say, of around 2 or 2.1 millimeters, and an inner diameter of 1.6 and or 1.7 millimeters. So it just gives you an idea of, although it looks really magnified on the screen, in reality, we're working with really miniature instruments. The ear canal itself, on average, the height is always greater than the width, or it should be. So you have more of an oval shape as opposed to a round cylindrical shape. And the average height, give or take, is about 9 millimeters, is just under a centimeter, and the width around 6 millimeters. So it is a very confined space. It sometimes doesn't reflect when you watch a video because everything's magnified. So I've got the more lateral plug of dead skin out. You can see this white peripheral matrix. And once again, this is where the ear canal is widened. So with Keratosis obturans, especially with the type grade 2, 3 and 4, you get a global widening of the ear canal. And the way that works is, so the inner 2/3 of the ear canal is made up of bone. And when you've got a dead skin plug like this, it compresses against the bony part of the ear canal. And that sheer pressure itself, think about this like a rubber ball, and it just gets bigger and bigger. And it can physically start to widen the bone. And also, the compression of the skin plug up against the canal wall initiates a process called bony resorption and remodeling of the ear canal. So sitting on the surface of the bone are specialist bone cells called osteoclasts. And when the wax plug or skin plug is compressed against the bone, it it causes dilation of the blood vessels, and that and also irritation of periosteum. So periosteum is almost like a thin membrane that sits on our bone, and it supplies the bone with all the blood and nutrients that it needs to repair and grow. And if the periosteum is irritated or inflamed, it activates these osteoclasts. And when the osteoclasts are activated, it starts to break down the bone into its core constituents, so it's all the minerals and tissues. And then all this recycled bone tissue and minerals is recycled via the bloodstream to other parts of the body where there's new bone formation. So the bone is always recycled. And the other type of cell that initiates new bony growth is called osteoblasts. So with keratosis obturans, because it's compressing against the canal wall, you typically get a global widening. And what I mean by that is the whole circumference of the ear canal itself that's become widened. In other similar conditions like benign osteonecrosis, whereby there's a lack of blood flow to the bone, and because the bone is deprived of all the blood and nutrients that it needs, the bone undergoes a process of necrosis. It starts to die and break away. Benign osteonecrosis is more localized. It's typically at the floor of the tympanic plate, which is the floor of the ear canal. And so that's one differential diagnosis between a keratosis obturans and benign osteonecrosis. And patients who typically have benign osteonecrosis are hypertensive. They have high blood pressure typically, which means there's less blood flow because there's so much pressure of the blood in the blood vessels. It's slower to flow across the body. And there's another condition called a cholesteatoma, which is very rare. And that's when you get a dead skin cyst that forms on the ear canal. Now, typically cholesteatomas form in the attic region of the eardrum, so the topmost region where the eardrum is most susceptible of being retracted, being pulled in due to negative middle ear pressure. So if you have a blocked eustachian tube, that means there's less air pressure. So the eustachian tube is a pressure equalizing tube that connects the middle ear, which is the cavity behind the eardrum, to the back of the nose. And it's responsible to try and equalize the air pressure. So the middle ear pressure is equal to the atmospheric air pressure, so the air pressure in the ear canal. If that eustachian tube gets blocked, and it typically gets blocked at the back of the nose where it connects, it means there's no air behind the middle ear. All the remaining air is absorbed by all the skin cells, the mucosal skin cells that line the middle ear cavity. And it creates negative pressure, a bit like when you're descending on an aircraft. So when you're descending on an aircraft, the air pressure in the cabin is greater than the air pressure behind your eardrum, and that causes your eardrum to get pulled in, retracted. And typically most people perform the Valsalva. You close your mouth, pinch your nose and blow, and you trap that air inside your nose. And what that maneuver does, it helps to force air up the eustachian tube, even if it's blocked, to kind of create positive middle ear pressure to kind of pop the eardrum back out. So the skin that lines the ear canal and also the outermost layer of the eardrum, as that dies and sheds, it should migrate outwards towards the entrance. But if you've got a retraction pocket, so the top part of the eardrum is sucked in, skin cells migrate the wrong direction. Instead of coming laterally out of the ear, they tend to migrate into the eardrum. And the dead skin cyst is, I call it a dead skin cyst, but it's metabolically active. The basal layer of the epidermis, which is the deepest layer, that is metabolically active, whereas the outermost layer of skin of the epidermis is actually dead skin cells. So the basal layer of the skin of the epidermis, they keep generating new skin cells. So there's a process called mitosis where the skin cells replicate themselves. So in essence, this dead skin cyst is self-growing, and it can get bigger and bigger. And when it gets bigger and bigger, it starts to release proteolytic enzymes, and these are digestive enzymes found in the skin cells, and these are destructive. They start to chew away at the flesh and bone. And this cholesteatoma, because it grows, it can grow inwards into the middle ear, it can cause a perforation, and then it can grow upwards towards the brain, so it can cause meningitis, a brain abscess. It can be potentially fatal, or it can grow to the back of the ear, into the mastoid region, which is the bone behind your ear canal, and cause mastoiditis. It can grow further inwards and affect the facial nerve, or it can grow forwards anteriorly towards the temporomandibular joint and cause jaw problems. So that's your typical middle ear cholesteatoma, but sometimes you get this formation of dead skin cells and a cyst in the ear canal. I keep calling it dead skin, but it's actually a skin cyst because, as I said, not all the skin cells are dead. And when you've got this cyst of skin cells in the ear canal, again, they form into a plug, a cyst, and they continues to grow. And similarly to a middle ear cholesteatoma, they release these proteolytic enzymes, which can then ulcerate the skin. It can expose the underlying bone, and it can just continue to grow. So with a canal cholesteatoma, a differential diagnosis to Keratosis obturans, again, typically you'll have discharge, you'll have otorrhea with a canal cholesteatoma. You don't typically have that with a Keratosis obturans. There's no active infection. In addition, you get localized erosion. So with a Keratosis obturans, you get this global widening of the ear canal. But with a canal cholesteatoma, you'll get it can typically happen at the back part of the posterior canal wall or the inferior canal wall, but it can also happen at the front part of the ear canal. Less so top part of the ear canal, but it is possible. So it's more of a localized erosion, and normally you'll get an ulceration of the skin. So the skin is the layer of skin is missing and the underlying bone is exposed. Benign osteonecrosis, sometimes you don't get discharge and sometimes you don't get an ulceration, so the skin is still intact. It's just the underlying bone is eroded away. So I always call a benign osteonecrosis a bottom-up condition. It's the bone underneath the skin that's decaying, and it creates a trench. Whereas a canal cholesteatoma, I typically call it a top-down pathology because it's the dead skin in the, or this not the dead skin, the skin cells, the skin cyst in the ear canal on the surface eroding downwards. Canal cholesteatoma typically is also with more older patients as well. With the Keratosis obturans, it's more younger patients. So we've used forceps, we've used the right correct there. We're bringing this forward slowly. So I'm just going to the back part of the ear canal, trying to glide in and push this away from the back part of the ear canal. So the view that you're experiencing with the WAXscope is very similar in terms of magnification to an ENT operating microscope. With an ENT operating microscope, you have binoculars really, so you're looking into the ear with both eyes. But it's not possible to visualize, for example, the eardrum at the bottom of the ear canal, which is about 2.5 centimeters away, with both eyes, because your interpupillary distance is too far away. It's too great to look at an object very small in the ear, deep. So what an ENT operating microscope does, it artificially converges the distance between your two eyes. So it tries to enable you to visualize wax or the eardrum deep in the ear with both eyes. So that gives you binocular depth perception. When you're using the WAXscope or an endoscope, you're not utilizing that binocular vision. You're looking at a monitor. So it's a monocular view. Now, it doesn't mean you can't get depth perception using monocular cues. It's just a different mechanism. For example, here I'm using the focus. So when the object is in focus, I can judge the depth. So it's just the remaining skin. It's on the anterior part of the ear canal. Again, this can be quite typical with Keratosis obturans. You get a lot of dead skin formation on the eardrum. There's just some residual skin, which I was very pleased that I could get actually with the WAXscope in the anterior recess. I'm just reducing the exposure slightly there. You can see it's just in the corner. It's just obscuring the view of the short process of the malleus, so the hammer bone, the top part. You get it's almost like a ball and socket. Well, the ball joint is spherical. And when I remove this, you'll see that short process of the malleus a lot clearer. You can see that spherical piece of bone at the top around 10 o'clock. So there's a thickened eardrum there where you can see that reflection. So again, that's quite common with Keratosis obturans. There's just some residual wax skin just near the entrance. So I'm just going to get that in focus. So this is how you get depth perception. You just adjust the focus. I'm going to mop that away. Well, I hope you enjoyed that video, guys. If you are interested in the WAXscope, please do email info@clearwax.co.uk. Thank you. Bye.